Anterior abdominal wall. Skin nerve supply. The cutaneous nerve supply to the anterior abdominal wall is derived from the anterior rami of the lower six thoracic nerves and the first lumbar nerves. The thoracic nerves are the lower five intercostal and the subcostal nerves. The first lumbar nerve is represented by the iliohypogastric and the ilioinguinal nerves. The dermatome of T7 is located in the epigastrium over the xiphoid process. The dermatome of T10 includes the umbilicus, and that of L1 lies just above the inguinal ligament and the symphysis pubis. The dermatomes and distribution of cutaneous nerves are shown. Blood supply, arteries. The skin near the midline is supplied by branches of the superior and the inferior epigastric arteries. The skin of the lumbar flanks is supplied by branches of the intercostal, lumbar, and deep circumflex iliac arteries. Veins. The venous drainage passes above into the axillary vein via the lateral thoracic vein and below into the femoral vein via the superficial epigastric and the great saphenous veins. Caval anastomosis and para-umbilical veins. Note the important indirect connection between the superior and inferior vena cava. This may permit the reversal of blood flow in patients with an obstructed vena cava caused by a large mediastinal or abdominal tumor. Note also the presence of small paraumbilical veins that connect the systemic skin veins in the region of the umbilicus along the ligamentum teres to the portal vein. This may provide an important portal systemic anastomosis in patients with obstruction of the portal vein, as in cirrhosis of the liver. Lymph drainage. The cutaneous lymph vessels is above the level of the umbilicus drain upward into the anterior axillary lymph nodes. The vessels below this level drain downward into the superficial inguinal lymph nodes. Superficial fascia. The superficial fascia is divided into the superficial fatty layer, fascia of Camper, and the deep membranous layer, Scarpa's fascia. The fatty layer is continuous with the superficial fascia over the rest of the body. The membranous layer fades out laterally and above. Inferiorly, the membranous layer passes over the inguinal ligament to fuse with the deep fascia of the thigh, fascia lata, approximately 1 finger breadth below the inguinal ligament. In the midline, it is not attached to the pubis, but instead forms a tubular sheath for the penis, clitoris. In the perineum, it is attached to each side to the margins of the pubic arch and is known as Colles fascia. Posteriorly, it fuses with the perineal body and the posterior margin of the perineal membrane. Superficial fascia and the extravasation of urine. The membranous layer of superficial fascia has beneath it a potential closed space that does not open into the thigh but is continuous with the superficial perineal pouch via the penis and scrotum. Rupture of the penile urethra may be followed by extravasation of urine into the scrotum, perineum, and penis, and then up into the lower part of the anterior abdominal wall deep to the membranous layer of fascia. The urine is excluded from the thigh because of the attachment of the fascia to the deep fascia of the thigh. Deep fascia. In the anterior abdominal wall, the deep fascia is a thin layer of areolar tissue covering the muscle. Muscles of the anterior abdominal wall. The muscles of the anterior abdominal wall consist mainly of three broad thin sheets that are aponeurotic in front. From exterior to inferior, these sheets are the external oblique, internal oblique, and transversus. In addition, on either side of the midline anteriorly, there is a wide vertical muscle called the rectus abdominis. As the aponeurosis of the three sheets pass forward, they enclose the rectus abdominis to form the rectus sheath. In the lower part of the rectus sheath, there may be a small muscle called the pyramidalis. The cremaster muscle is derived from the lower fibers of the internal oblique. It passes inferiorly as a covering of the spermatic cord and enters the scrotum. Rectus sheath. The rectus sheath is a fibrous, long sheath that encloses the rectus abdominis muscle and pyramidalis muscle, if present, and contains the anterior rami of the lower six thoracic nerves and the superior and inferior epigastric vessels and nerves and lymph vessels. It is formed by the aponeurosis of the three lateral abdominal muscles. The internal oblique aponeurosis splits at the lateral edge of the rectus abdominis to form two laminae. One passes anteriorly and one posteriorly to the rectus. The aponeurosis of the external oblique fuses with the anterior lamina, and the transversus aponeurosis fuses with the posterior lamina. At the level of the anterior superior iliac spines, all three aponeuroses pass anteriorly to the rectus muscle, leaving the sheath deficient posteriorly below this level. The lower crescent-shaped edge of the posterior wall of the sheath is called the arcuate line. All three aponeurosis fuse with each other and with their fellows of the opposite side in a midline between the right and the left recti muscles to form a fibrous band called the linea alba, which extends from the xiphoid process above to the pubic symphysis below. The posterior wall of the sheath, however, has no attachment to the muscle. The transversus tendinous intersections, which divide the rectus abdominis muscle into segments, are usually three in number, one at the level of the xiphoid process, one at the level of the umbilicus, and one between these two. Surgery and tendinous intersections of the abdominis muscle. Note that the anterior wall of the rectus sheath is firmly attached to the tendinous intersections of the rectus abdominis muscle. The posterior wall of the sheath, however, has no attachment to the muscle. Linea semilunaris. The linea semilunaris is the lateral edge of the rectus abdominis muscle. It crosses the costal margin at the tip of the ninth costal cartilage. Conjoint tendon. The internal oblique muscle has a lower free border that arches over the spermatic cord or the round ligament of the uterus and then descends behind and attaches to the pubic crest and the pectineal line. Near the insertion, the lowest tendinous fibers are joined by similar fibers from the transversus abdominis to form the conjoint tendon, which strengthens the medial half of the posterior wall of the inguinal canal. Inguinal ligament. The inguinal ligament connects the anterior superior iliac spine with the pubic tubercle. The ligament is formed by the lower border of the aponeurosis of the external oblique muscle, which is folded back on itself. From the medial end of the ligament, the lacunar ligament extends backward and upward to the pectineal line on the superior ramus of the pubis, where it becomes continuous with the pectineal ligament, a thickening of the periosteum. The lower board of the inguinal ligament is attached to the deep fascia of the thigh, the fascia lata. Fascia transversalis. The fascia transversalis is a thin layer of fascia that lines the transversus muscle and is continuous with a similar layer lining the diaphragm and the iliacus muscle. The femoral sheath of the femoral vessels is formed by the fascia transversalis and the fascia iliaca. Inguinal canal. The inguinal canal is an oblique passage through the lower part of the anterior abdominal wall. In males, it allows structures to pass to and from the testis to the abdomen. In females, it allows the round ligament of the uterus to pass from the uterus to the labia majus. The canal is approximately 1.5 inches 4 centimeters in length among adults and extends from the deep inguinal ring downward and medially to the superficial inguinal ring. It lies parallel to and immediately above the inguinal ligament. The deep inguinal ring is an oval opening in the fascia transversalis and lies approximately zero point 0.5 inches 1.3 centimeters above the inguinal ligament. The margins of this ring give attachment to the internal spermatic fascia. The superficial inguinal ring is a triangular shaped defect in the aponeurosis of the external oblique muscle and lies immediately above and medial to the pubic tubercle. The margins of this ring give attachment to the external spermatic fascia. Walls. Anterior wall. External oblique aponeurosis reinforced laterally by origin of the internal oblique from the inguinal ligament. Posterior wall conjoint tendon medially, fascia transversalis laterally. Roof or superior wall, arching fibers of the internal oblique and transversus muscles. Floor or inferior wall, inguinal and lacunar ligaments. Function of the inguinal canal. In males, the inguinal canal allows structures to pass to and from the testes to the abdomen. Normal spermatogenesis occurs only if the testis leaves the abdominal cavity and enters a cooler environment in the scrotum. In females, a smaller canal allows the round ligament of the uterus to pass from the uterus to the labia majus. In both sexes, the canal also transmits the ilioinguinal nerve. Mechanics of the inguinal canal. The inguinal canal is a site of potential weakness in both sexes on coughing and straining, as in micturition, defecation, and parturition. The arching lowest fibers of the internal oblique and transversus abdominis muscles contract and flatten the arch. In turn, this lowers the roof of the canal toward the floor and virtually closes the canal. Inguinal hernia. An inguinal hernia occurs above the inguinal ligament, whereas the femoral hernia occurs below the inguinal ligament. Inguinal hernias are of two types, indirect and direct. Indirect inguinal hernia. The hernia sac is the remains of the processus vaginalis. An indirect inguinal hernia is more common than a direct inguinal hernia. It is much more common in males than in females. It is more common on the right side. It is more common in children and